Dr. Stuart J. Beldner is an attending physician in electrophysiology at North Shore University Hospital. He has board certifications with the American Board of Internal Medicine for cardiac electrophysiology and cardiovascular disease. He is an associate professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell and has fellowships with North Shore University Hospital and the Hospital of the University of Pennsylvania. Dr. Beldner is a dedicated, loving family man and a high-level triathlete. Hi, Dr. Beldner.
Good afternoon.
All right. Thanks for being here. Really appreciate it.
My pleasure.
I want to get right into it. So I'm just going to start and say, what is electrophysiology? And in your answer, if you could try to compare it a little bit to cardiology, that will help out people to understand.
Perfect. So I guess I should start off by saying that cardiology is the study of the heart and cardiovascular diseases. And cardiology encompasses things that could be related to things like heart attacks or pump function, muscular function of the heart, and of course electrophysiology, which is a focus on the electrical activity of the heart. Electrical activity of the heart could be anything from slow or fast heart rates.
Okay.
Under the domain of what I do, we often take care of people who have some degree of autonomic dysfunction, changes in blood pressure. Seems to be somewhat related to the autonomic nervous system in relations to heart rate and variability. But if I were just to say, what is electrophysiology? It's the study of arrhythmias. AFib is the most common rhythm problem that we see. It happens to about 10% of people by the time they reach the age of 80. And there are things that make you more likely to have it, such as hypertension, diabetes, structural heart disease. But an overall prevalence of up to 10% by the age of 80, that's a lot of people.
That's a lot of people.
And a lot of people are living to older ages. It kind of could be considered an aging process of the heart. Just like as you get older, you get some arthritis, or your skin isn't as pliable. The stiffness in that we can often see on the outside is still going on the inside. So if you imagine your heart is a muscle and it's been pumping blood to your body for 60, 70, 80 years, there are structural changes that are going to occur that make you more likely to have atrial fibrillation.
Okay.
That's not to say we don't see it in 20-year-olds and 30-year-olds. We do, and there are different forms of fibrillation, but it's that common, and that's why it's such an important field for us to continue to improve on. In general, ablation is a way of injuring cells or creating scar strategically in the heart. We are looking for misbehaving cells, misbehaving areas of the heart, and we are trying to injure them so that they can no longer generate any electrical impulses.
When you're dealing with AFib, it's always in the same spot, right? It's always around the pulmonary veins at the top. So when they talk about isolating a vein, they're trying to burn or freeze. They're trying to stop all that signal from coming in, and that's what gives you that protection from having any further arrhythmia. That's my understanding.
Yeah, so that's a pretty good understanding, actually. I can tell you're well read on the subject.
Okay, thanks.
The ablation that you're describing is the most common ablation we do. That's the atrial fibrillation ablation. Okay. But as you're very well aware, we do other types of ablations as well. When you talked about atrial fibrillation or pulmonary vein ablation, 90% of the time when people have atrial fibrillation, it's triggered or initiated by extra beats that come from the pulmonary veins. There's actually left atrial tissue within the pulmonary veins, and the left atrial tissue within the pulmonary veins acts chaotically and is able to generate electrical impulses that leave the heart a receptacle heart to have the atrial fibrillation. So by going up to the heart and approaching the pulmonary veins and isolating them, creating an electrical roadblock so those signals cannot reach the heart, we're able to effectively decrease the triggers for people to have atrial fibrillation. And that's really the crux of that ablation procedure.
My father, may rest in peace, had three ablations, and the first two did nothing.
Medicine moves at the speed of light, and things and advances have come over the last, 1997, so the last, 25, 30 years.
Sure.
we have identified better ways to do the ablation. So when we first started doing ablations for atrial fibrillation, it's incredible to even think about it, but they were like 8-hour procedures.
Okay.
Where we would try to make the person go into atrial fibrillation and map the actual place where the fib was coming from.
Wow.
And then we used catheters that were designed for other purposes to do this ablation procedure. And it was painstaking and difficult, and a lot of inflammation during the procedure itself, so that the true effect wasn't always long lasting. And in fact, when I was training and doing my
Can I stop you that really question?
Yeah.
When you say the effect, okay, so you're saying that if you don't kill it completely, or you just, if the scar doesn't come after you deliver your charge, then it could just, you have to just do it again. That's what happened with him.
So you can wound it, and then it recovers. And then the impulse that was supposed to be walled off can now regain access to the heart.
Oh, wow.
Sometimes it would be so slow that it wouldn't be clinically significant, not cause arrhythmia. And other times we would be doing a repeat procedure. And back in the early 2000s, when I was learning how to do the procedure, the redo rate, the repeat procedure rate was quite high. And when we did these repeat procedures, almost all the time the pulmonary veins were reconnected.
Oh.
So it was not until we were able to achieve durable pulmonary vein isolation did we really start seeing this procedure being so widely adapted. The evolution of ablation, which started out for AFib, which started out as a surgical procedure where people were opening up the chest and doing different, I'll call them lesion sets, but different ablation strategies to try and take care of atrial fibrillation. It turns out that the morbidity and mortality from the early procedures were quite high, but the lesion sets or the ablation strategies that incorporated the pulmonary veins had the highest likelihood for success.
Okay.
So a really smart guy, said, well, why are the pulmonary veins so important? And he went ahead and did a study where he put wires into people's pulmonary veins and gave them all kinds of adrenaline until they went into atrial fibrillation. And he found that when he did that, 90% of the time, the first beat that caused atrial fibrillation came from the pulmonary veins. We mirrored his procedure. We gave people adrenaline until AFib happened, and then we ablated the pulmonary vein that was causing the problem, or the area of the pulmonary vein that was causing the problem. But as I said, that was an 8-hour procedure, and we found that most of the time we were doing all 4 pulmonary veins. And if we didn't do all 4 pulmonary veins, someone
could have missed it.
someone would come back months or weeks or years later, and we would find out that it was the other vein that was now causing the problem.
So the reason you did all of them was just to make sure you got it, double down.
So now we don't, most of the time, most people who do an AFib ablation, they're not doing provocative testing before the ablation, meaning they would come in, and in general, we understand that anybody who comes in with an AFib ablation should leave with their pulmonary veins ablated, isolated, and we therefore start with that before we do any provocative testing.
Oh.
And that is why the procedure is safer, faster, and, to be honest, more effective.
Is there a point where you have too much ablation?
So it is programmed cell injury that we're trying to do, but the answer is it depends on what kind of ablation you do, because you are creating some damage. But with respect to atrial fibrillation, the back wall of the left atrium is kind of tethered, and it doesn't actually have any mechanical function. So it's really the front part of the left atrium that does the squeezing. And the amount of cell damage or the amount of ablation that we do around the pulmonary veins is very minor overall compared to the overall pumping function of the heart. And we can measure that mechanically with different tests and things, should we need to do that or want to do that. The concept of atrial fibrillation that isn't related to the pulmonary veins, I mean, kind of hinted at it, right?
Okay,
So if patients are coming back to the EP lab for recurrent atrial fibrillation and we're finding their veins isolated, well, gee, where's the atrial fibrillation coming from?
Okay.
And there have been some studies where injecting alcohol into a vein, that's called the vein of Marshall, that runs in an area of the heart that is very important, it turns out, for atrial fibrillation. And kudos to the guy who did most of the research on that.
So by pumping alcohol into that?
So it's It has a couple of functions. There's this tiny little vein runs in an area of the heart that is important to create an area of scar to decrease the amount of tissue able to fibrillate. Okay. It also allows creation of a line of block, an area to prevent perpetuation of circuits that can live in the heart in the setting of atrial fibrillation. And it also is richly innervated, has a lot of autonomic nerve endings in that area. So by injecting alcohol into this vein of Marshall, we're creating a small heart attack in an area that allows us to affect the autonomics of the heart, allows us to create a line of block from a shifting signal that often travels around the mitral valve, and it allows us to decrease the amount of tissue available to fibrillate. It turns out that there are a couple of studies that have shown that in people with persistent atrial fibrillation, you can increase the success rate significantly by incorporating that vein in your strategy. So with respect to non-venous atrial fibrillation, it's one of the few things that we have or understand that has data on decreasing incidence of atrial fibrillation outside or apart from pulmonary vein isolation. What we do is we put our catheter against the myocardium, the heart muscle. We are putting the catheter on the wall of the heart in the desired area, and we deliver energy, current. And we have a grounding pad, so we're able to deliver energy to a specific spot in the heart, and we're heating up the tissue, basically. And the heating of the tissue denatures the proteins, and as those proteins denature, we're causing cell injury and hopefully cell death, creating a small amount of scar.
How long does that take?
So most of the lesion happens in the first 10 seconds, and depending on what the area we're ablating, we can deliver energy from anywhere from just a few seconds up to several minutes. I typically have 3 catheters in the heart when I do an atrial fibrillation ablation. I have a reference catheter, an ultrasound catheter, and the treating catheter. Now we have catheters that we can steer and deflect, and it's not just a matter of pushing and turning. We're able to actually use guided sheaths, guided catheters, and we're able to fine tune where we're delivering these energies. So it's just a much needed advance to an old technology. We have learned a lot of different ways to deliver the energy more efficiently. So, for example, there have been some studies that show that general anesthesia increases the likelihood for success. And that might make sense if you think about if I'm delivering heat energy, if I'm delivering a very hot lesion or focus in your heart and it's painful, someone might take a deep breath or rotate or move away, and you may not be delivering that energy exactly where you think you're delivering it. So general anesthesia, and then once we start with general anesthesia, we're able to control ventilation. So we can do very fast breathing, or we can even do apnea, meaning someone apnea, holding breath. We can turn the vent off for a minute or two while we deliver lesions, so we know that the heart's not moving within the chest, right? Because every time you take a deep breath, the heart moves in the chest.
So by creating apnea, you're making sure that you deliver precisely on point.
And the mapping systems that we use that are able to allow us to do these with very limited exposure to X-ray or radiation, right? Because X-ray is radiation, fluoroscopy. And if we are using these mapping systems to track the catheter and mark reference points where we've made the lesions or delivered the treatment areas, the precision for those mapping systems has evolved dramatically. So between the ability to control respiration, the ability to be more precise with our mapping, and most importantly, having catheters that can deliver the energy more efficiently, allow us to have a much higher success rate. When we deliver radiofrequency, we're often limited by the temperature of the tip of the tissue, of the catheter. What that means is we don't want to burn the surface of the heart. We want to deliver heat down within the myocardium, inside the heart muscle. And if we're burning the surface of the heart, we're not delivering the energy where we need it to be. So we're limited a lot of times by temperature. And we also don't want to create this heat. A lot of the body has water in all of its tissues. And we can actually boil that water and cause steam pops. And if the steam pop pops into the heart, well, that's less of an issue than if the steam pop pops the other way, because then there could be a hole in the heart. So we have developed more efficient ways and safer ways to deliver the energy.
Okay.
So the procedure is safer, faster, and more effective than it has ever been. And this pulse field ablation
Right, that's how I was gonna-
that you're talking about
Yeah.
promises to be even faster and safer.
Like I've read that it's like 98, 99%. I mean, I know this is just top line stuff that I'm reading, but I've heard that the esophagus, there was no damage.
So I would say this is that there's no permanent damage.
Okay.
I would say it's also important to mention for the people who are out there saying, "Oh my God, I want to get a line for pulse field ablation." That sounds like the greatest thing ever.
No, I know there are different things
The success rate for the pulse field ablation is no higher
than radio.
than the radio frequency.
Sure.
But in a world where safety is probably the most important thing, right? Do no harm.
Right.
The technology for pulse field ablation allows for protection of the esophagus, which is the most dreaded complication from an AFib ablation. Atrial fibrillation ablation. When you use heat or even freezing, the cryo, you can thermally injure the esophagus and actually create a connection between the esophagus and the left atrium.
I know they're both thermal.
Right.
But the cryos has a little bit more of a high risk.
The cryoballoon studies showed that there were some complications that have pretty much gone away with radiofrequency.
Okay.
That came back a little bit with cryo, although I think that those things have been evolved as well. But in general, the cryoballoon can affect the phrenic nerve, as can radiofrequency.
Okay.
They can both affect the esophagus, and these are significant complications from atrial fibrillation ablation. The pulse field ablation, which we probably should talk about if we're just going to...
Well, that's what I was, trying to lead towards, is that, again, I'm just reading top line stuff, doctor, but I've heard that there's basically no, because they're not delivering high energy. It's such a low amount that, at least from what I read, and I know in your mind you're thinking, okay, but it's just creating a little bit of perforations again, and then it's dying on its own, and it kind of feels very unaggressive.
So what it is so we talked about thermally injuring the tissue. We talked about radiofrequency burning the tissue. We talked about cryo freezing the tissue.
Right.
And the idea is that proteins will die or fall apart at extremes of temperature. So by heating or freezing, we can achieve cell death and strategically cause cell death in the areas to achieve the desired effect. The scarring. Pulse field ablation is very interesting. So all the cells in the body have their own frequencies by which their cell membrane can be disrupted.
All right.
Lung cells are different than heart cells. Esophageal and phrenic nerve cells are different than heart cells. So you can deliver a focused pulsed field and cause what we call electroporation, like you said, affect the cell membrane,
right,
to cause the cell to die and create that scar.
Right.
And because it's not thermal, you don't get those scars in unintended areas. Because you program the frequency at which it's specific for the heart, you're not affecting the esophagus or the phrenic nerve. So those patients who do get temporarily phrenic nerve palsy or weakness,
sure,
during the procedure, it always comes back, is what the experience has been thus far.
Okay, I'm not trying to be a cheerleader for PFA, but I'm just wondering, like, that just seems so blatantly game-changing.
Yeah, so there are plenty of cheerleaders for PFA. We've been waiting for this technology for a while. We're ablating atrial fibrillation all the time. It's so prevalent, and if we can offer a safer procedure,
Faster one.
faster, safer.
Right.
I mean, when we say faster, it's not that
the ORs can be, you could put 2 people instead of 1, or 3 instead of 2, or...
I was going to say it a little differently,
Okay.
because it's not that I have somewhere else to be. That's not the faster, but the purpose of faster is
helping more
that
people. Right.
helping more people, and complications are directly related to the duration of the procedure. So the amount of time you're under general anesthesia, the amount of chance to have a clot form in the heart, the amount of time that you can be exposed to manipulation or perforation. So complications directly related to the length of the procedures.
Can pulse field be used for everything?
So not right now.
Oh,
So
couldn't be used on what I have.
not right now.
Oh, okay.
But like everything else, like I said, technology moves at the speed of light.
Okay.
And the current FDA-approved delivery system is a single-shot technology. So you can put that up to the pulmonary veins. You can do some other things with it, but it is not built to do something like a PVC.
Okay.
It is not built to do point-by-point ablation.
Okay.
There are point-by-point ablation solutions that the companies are working on. The technology is going to evolve to the point where we'll be able to use both pulse field point-by-point as well as single-shot catheters. There's thermal injury and the PFA type strategies, but I think that they are going to merge, and I think that eventually pulse field will win, but it'll have to be a pulse field RF type of combination for the reasons that I'm saying. So again, 90% of the time, the pulmonary veins are triggering atrial fibrillation, and much like they did in the initial studies, one of the parts of my procedure is I give people adrenaline after the procedure to look for that 10%.
Wow.
And if I find a spot or an interesting beat, I need to map that. And the current single-shot PFA catheter is not good for that. There are a lot of PFA solutions that are coming out, pulse ablation solutions that are coming. It's a very exciting time. Northwell's been ahead of doing a lot of the trials of these technologies. So we've been doing it for years, but now we have FDA approval for this solution,
right,
and hopefully more to come. But I just didn't want to touch base, just leave it as everyone's saying, wow, I can't wait to get pulse field ablation. But there are some things that RF, or radio frequency ablation, is still ideal.
Persistent atrial fibrillation, where it's constantly happening, then they're in danger of a stroke. They're in danger of, right? They have to make a move, take a medicine, have an ablation.
So so
I know it's all specific, patient specific.
No, it's not just specific. It's very broad based, right? So there are some people that will be at increased risk for complications related to atrial fibrillation, such as stroke. And if someone decides in persistent arrhythmia, doc, I'd like to see how I do over the next 6 months to a year, and they leave themselves in atrial fibrillation.
Okay.
It can be harder to treat their atrial fibrillation. There are studies that show that the earlier the intervention, the better that people do.
If someone came to you and said to you, listen, I'm on the borderline. I'm having paroxysmal, occasional, and I am a candidate for ablation. What would you tell them if it was someone that you really had a vested interest in that was beyond the typical patient? Would you say, listen, the risk of living with this, of the risk of down the road problems is enough that you should do it, as opposed to the risk of immediate side effects? What would be your answer to that person? What would be your suggestion?
The desire to intervene early in AFib is because we're more likely to be successful. So depending on the frequency, burden, and symptoms of arrhythmia, I might be more zealous with the recommendation. I think that also is dynamic as well, right? So I have a patient who I've been taking care of. She's a physician at North Shore, a lovely woman who is very anxious about the concept of ablation, but she's miserable when she has her AFib.
Okay.
But her episodes are less than an hour, and they're somewhat infrequent. And in her case, we were waiting for pulse field ablation to come out, because she didn't want even the 1 in 10,000 risk of a left atrial esophageal fistula. So she's now ready, and in her case, say a year ago, I was like, listen, the trial's coming out, we're gonna have the data, we're gonna know where we stand with this, we've got a lot of these under our belt because we've been part of the trial, I think it's good, let's just wait and see how it comes, versus someone who has been cardioverted, say once a week for recurrent arrhythmia, who has had maybe complications related to the arrhythmia, maybe a weak heart muscle from AFib, or heart failure from AFib, or God forbid a stroke. Those things may make me want to be more aggressive. Years ago, there were studies on what to do with asymptomatic pathways, meaning that, okay, someone goes for a pre-employment physical, or they go for their yearly
see
physical.
something, but they're not feeling it.
Yeah, so what do you do in that circumstance?
Leave it.
And well, for years we would just say leave it, but now the general thought is that if someone's under the age of 35, that the likelihood of them getting into trouble with that pathway over their lifetime is high enough.
I get it.
And the risk of the procedure is low enough and the efficacy is high enough that we're taking asymptomatic people often to do that if we cannot prove that the pathway is weak. And there are different testing that we
Are there
can do
downsides to that, though?
to doing a procedure.
To doing it because something might happen, and yet they're going to have a side effect that would be worse if they not if they had it, but that the chances they still might not have it.
The complication rate for that procedure right now is so low. If we know where the pathway is coming from and it's in a safe area, it is safer to do the procedure than wait to see what happens.
Okay.
Under certain circumstances. I don't want to make that as a blanket statement.
Should medicines and knowing that you're resistant before you would go towards something that could take on some scarring or some damage, is that the optimal fix before ablation?
Well, I would say that it's patient specific, right?
Okay,
so
sure.
there are people out there that would say, why would I have a procedure if there's a pill for it?
Right.
Or people out there would say, why would I take a pill if there's a procedure for it? Most people that I know of, and maybe it's the bias, the patient selection that I see, most people don't want to take pills.
Yeah, they don't want that part of their life.
Yeah.
Right.
And pills have side effects. And,
Sure.
And quite frankly, the pills are not, I don't know one pill that is as effective as the ablation procedures. And if we think that the ablation is of low enough risk, it's never going to be no risk, right? It's never going to be no risk to moving wires around the heart. But it may be better to assume the one-time risk than to say, okay, I'm going to take this pill for the rest of my life.
When you're ablated, do you, and I can answer it because I've had it myself, does it change your life? Is there any, can I not have a drink when I go out? Should I sexual activity? Are there things that I'm now have to be a little bit more cautious of?
So I'm going to answer the drinking question first. And the answer to that is there are certain lifestyle modifications that have to be taken into account regardless.
Sure.
So we talked about in the beginning of the podcast, we said things like hypertension, structural heart disease. We didn't even touch on sleep apnea. These things are going to make you more likely to have arrhythmias. And if I can get the problem that you have today and you don't address the underlying issues, you will develop new problems.
Okay.
And alcohol is I don't know if it's a big problem, but alcohol is an issue. I mean, it's a toxin and a diuretic, and it causes arrhythmias. And the recommendations are always going to be patient specific, and it depends on how much alcohol you want to drink.
A few beers on the weekend, and not that it's ever a few beers, but light recreational. If we're just talking about drinking, I mean, I don't want to make it seem like this is what this is about, but you know, you're saying that if you're a full-fledged an alcohol problem, right, then you're going to have some issues there. But if you're just a social drinker, I mean, does that typically manifest itself in more to have AFib?
It can.
Okay.
So in general, the counseling that I would give my patients would be, if we did an ablation today, and they're like, okay, doc, could I have a drink tomorrow? I would say, well, we did an ablation today. Let's wait and make sure, if we think we got it, right? So 6 months goes by and you haven't had a blip of arrhythmia. And then you say, great, it's been 6 months, I'm fixed. And then you introduce alcohol and you go right back into arrhythmia. I mean, we've identified a trigger.
Okay.
If it's
have you identified that? I mean, does that?
Yeah, we've identified. Like, there are people who continue to have arrhythmia because they're drinking. It's
wow.
Clear. Or people who don't want to treat their sleep apnea, or people who don't want to lose the weight, or people who can't control their blood pressure.
Okay.
I mean, lifestyle is
big.
It's big, but it has to be done irrespective, and there are plenty of studies of that. In fact, with respect to lifestyle modifications, I mean, beyond the scope of our discussion today on technologies of ablation, which is what we came to talk about, things like yoga and Tai Chi, these are things that have been shown to decrease the incidence of arrhythmias as well.
Wow.
So these non-lifestyle, these non-pharmacologic, these lifestyle modification things.
Is there any way to turn it around? Like, can you stop? Like, once you're having arrhythmias, is that considered physiological? And or is there a way to actually change your life to a point where you're not going to have it anymore?
I've seen both.
You've seen that?
It's very uncommon. I mean, people are good with lifestyle modifications in the short term.
Okay.
But
to hold on to it to a point where it would even make a difference.
It's tough.
Okay.
But it has to be had. That conversation has to be had, and it has to be impressed upon. Like, hey, this is a warning sign. This AFib you're having is a warning sign. you need to get your hemoglobin A1C, you need to get your diabetes under control, you need to treat your sleep apnea, you need to participate in an exercise program, and you need to do this is something we can fix today,
right?
But you can get in, this could come back.
I remember coming to in the whatever it is, post-op area, and you were standing there and you said, you've been there for a while and you didn't see any PVCs. So it happens immediately.
Yeah, so let's talk about that a little bit, because we've been focusing on pulse-field ablation, electroporation, and ablation of atrial fibrillation. So what we did, and I hope it's okay to share your information.
Please do.
It up. You had a premature ventricular contraction.
I had a 25% burden.
You had a focus of irritable heart cells that we mapped near your mitral valve, and that beat was firing at a frequency of almost 1 every 4 beats for you.
Right.
And what we essentially do is we go from the veins of the leg, we go up to the heart, and every time that beat goes by, we are sampling electrical activity. And eventually we will find the cells that are generating, or the area of the heart that has the cells that are generating that impulse.
Okay.
And that impulse could be located on the surface of the heart, in the outside of the heart, or somewhere in between. So depending on how deep we have to deliver that energy depends on how we are going to approach it.
Okay.
And if in your circumstance that you're describing is we found the beat, we delivered the energy, and the beat went away.
Okay.
But we don't know if we just wounded it or if we injured it permanently.
How long does that take? Like if that was in March of 2021. So now it's a few years, and I have to be honest, I feel great as in comparison, where I would go for full days and maybe even a couple days at a time where my heart was actually skipping every other beat. So I don't have that. I haven't had that since you did your work. But there are little, now I'm noticing more that I'm having more PVCs, and it starts to come back. Is that a sign where only I could tell you, and then I would wear a monitor and you'd say, Lenny, we should touch this up?
So remember, as you pointed out, so you and I know each other for many years, and you had seen other electrophysiologists even before me, and we had decided it had been a decision based on monitors that you had done that you had more than one spot.
Right.
And as you said in the beginning of the conversation, so
yep.
If you have more than one spot, the reason why we decided, listen, this is medical therapy, how can we ablate several spots? But as you pointed out, the symptoms got so bad where you were having it at such a high frequency, and there were periods of time where it would be every other beat.
Long periods of time.
That turned out that there predominant focus evolved. So one of the foci that you had became more robust and more active, and because of that, we had a frequency by which we were able to map that. So you have other spots that, as we've talked about, if it's at a low frequency, we can just watch.
I remember there was like 2 weeks or 3 weeks right after it, if you remember. I came in and it was like, I was so uncomfortable, but then all of a sudden, bang, it just happened. And I still, I can't figure out what happened, but it just all of a sudden the scarring took hold.
I think it was you had a lot of swelling from the procedure.
Oh.
And it took some time for the swelling. Just like if you bang your elbow, your elbow's going to hurt more tomorrow than it did today.
Okay.
And that swelling took some time to resolve, because as I remember, it wasn't a lot of arrhythmia you were having. It was a lot of non-specific type symptoms.
Just uncomfortable, more. Yeah, it was.
And then all of a sudden, boom, you just got better.
Yeah.
Probably the most important thing that I would say during, whoever will be watching this podcast, is that most of these arrhythmias that we've been talking about, you and I, are not life-threatening. That's not to say there aren't life-threatening arrhythmias, but it is a very important thing when you're sitting down across your doctor and having your conversation. Doc, is this a life-threatening arrhythmia? Like, do I need to do something right now?
Right.
And that question needs to be answered. And I tell everybody who comes into my clinic, whether it is or it isn't, this could be a problem. This is not likely to be a problem. This is something that we're doing just for symptoms. This is something that we're doing to prevent complications. And there are different ways to approach that. And all of that is wrapped in onto how I make the recommendation of how soon things need to be done.
Okay, so that was a great answer, and it kind of covered everything. So the reality of it is it is case by case. It is based on your quality of life versus what really could happen. And if it's really not life-threatening, then perhaps it's lifestyle, perhaps it's medicine, and then perhaps maybe it is. You know, like the young lady you were talking about that was waiting for the PFA. Did she have the PFA?
She's on schedule.
Okay. Doc, thank you so much for being here.
Thank you, Lenny. This was fun. A lot of fun. I'm sorry my hands are sweating. I was getting a little nervous.
Nah, you did great. You did great.